I want to tell you about one low testosterone case that completely changed how I treat men. On paper, it looks simple. Total T at 150, classic low T symptoms. The easy answer was to start TRT protocol and then move on. But when we dug deeper into his story, the meds that he's been on since he was a kid, the chemicals that he was exposed to, and his whole endocrine system had been pushed around for years, it rewired the way that I think about every guy that walks into my office. I'm Dr. Douglas Christensen, a naturopathic doctor focusing on men's hormones, metabolism, and risk reduction. Over the years, I've learned a lot from my own training and from people like Dr. Thomas O'Connor, the anabolic doc, who built his entire field around harm reduction, deep lab work, and taking men's androgen health seriously, especially when they've been on steroids or long-term unmonitored TRT. Today, I'm going to share the case that made me stop thinking low T equals TRT and start asking why are hormones failing in the first place. So I'll introduce you to the pillars of health and risk reduction that moves testosterone and long-term health, how environmental chemicals, plastics, and endocrine disruptors really are attacking your hormones, and why I'm deeply concerned about putting kids and teens on SSRIs and steroid medications as a first-line solution when we know they can disrupt puberty and development. I'll give you the data, and then you can decide if I'm crazy for seeing the pattern here. Now let me introduce you to a typical patient I've seen versions of many times throughout the years. Mid-30s guy, on paper, we have low energy, low libido, brain fog, increased belly fat, some anxiety, not recovering from workouts, and when we run the labs, you'll see total testosterone anywhere from 100 to 300, free testosterone from 45 to 80, sex hormone binding globulin above 45, and estradiol is around 45 to 60. He's already been told by another provider, your numbers are low enough that you can start TRT, which, easy checkbox. But his history stops me. As we talk more, we find out that he's been put on SSRI as a teenager for anxiety. He had several courses of systemic steroids like prednisone for asthma flare-ups as a kid. He grew up around plastics, microwaving food in plastic containers, drinking from plastic bottles, canned foods, like every other millennial kid. He's also been on and off various psych meds throughout the years. In other words, his HPG axis, how the brain communicates to the testes, has been getting pulled from multiple directions since puberty. And this is where my naturopathic training kicks in. We don't just ask, what's the number and what drug do I give? We ask, what broke the system? And can we fix any of that before we lock into a lifelong replacement? This is also where Dr. Thomas O'Connor's work influenced me. Dr. O'Connor, the anabolic doc, now known through his testosteronology work, has spent decades caring for men who used anabolic steroids, SARMs, and aggressive TRT protocols, and ended up with androgen-induced hypogonadism, and even cardiovascular risks with real damage. His approach is deep history, deep labs, harm reduction, and respecting androgens as a powerful drug, not toys. Watching his content and reading his work reinforced something my naturopathic training already pushed me towards. Don't just hand out testosterone casually. Understand the whole endocrine story. And when you do use TRT, build it on top of real risk reduction and lifestyle framework, not just in place of it. So with this patient, instead of starting testosterone and moving on, we zoomed out and assessed the whole picture that testosterone alone cannot fix. Now, when I say root cause as an ND, I don't mean we magically cure everyone's low T without ever using TRT. I mean, we start with the pillars that affect testosterone and long-term risk. Number one, sleep and circadian rhythm. Deep sleep is where a lot of your GH and testosterone rhythm is set. Chronic sleep deprivation blunts brain communication to the testes and lowers your testosterone. Fixing sleep, timing, duration, apnea is a non-negotiable. Number two, nutrition and metabolic health. Insulin resistance and excessive visceral fat suppress testosterone and increase aromatase. Fixing blood sugar, protein intake, micronutrients, and overall diet moves testosterone and lowers cardiovascular risk. Third, being muscle and resistance training. Muscle is not just aesthetics, it's an endocrine organ. Building and using muscle improves insulin sensitivity, lowers inflammation, improves androgen receptor signaling, and sends your brain a clear, we need this system signal. Number four, stress and HPA axis. Chronic stress and elevated cortisol blunts the HPA axis. We can't talk about low T without talking about the stress system, and when needed, tapering or minimizing exogenous steroid use. And number 5, environmental exposures. This is where endocrine disruptors, plastics, and chemicals come in. They're not only the cause, but they are absolutely part of the equation. For this patient, we started working those pillars while we dug deeper into the why behind this low T. Now let's talk about something that sounds like a conspiracy until you actually read the literature. Endocrine disrupting chemicals, things like phthalates, bisphenol A or BPA, parabens, and other phenols are everywhere. They're in soft plastics, food packaging, can lining, personal care products, the list goes on. Large studies show that phthalate metabolites are detected in about 75% of Americans, often higher in children. BPA is found in urine of at least 90% of subjects in the US, Germany, and Canada. These compounds bind to estrogen receptors and act like weak estrogens, interfere with androgen receptor binding, disrupt LH receptor signals in the Leydig cells, and are associated with decreased testosterone, decreased sperm quality, changes in your brain-testy communication, and increase in sex hormone binding globulin in observational studies. One review literally spells it out. Environmental endocrine disruptors are associated with decreased steroid hormone levels in male reproductive disorders, and mixed exposure is linked with reduced free androgen index and altered sex hormone binding globulin. So when I say the government is attacking our huevos, what I really mean is we've allowed an environment where chemicals that mimic or block our hormones are everywhere. Regulators are slow and often captured, and we're watching male reproductive health markers like sperm count, testosterone levels, testicular cancers. They are all trending in the wrong direction over decades. Call me crazy, but when you see endocrine disrupting plastics, plus ultra-processed diets, plus chronic stress, plus kids medicated from a young age, and then you see a wave of low T in 20s and 30s and 40-year-olds, it doesn't feel random. Now let's touch on the third rail: psychiatric drugs and steroids in young people. We have emerging data that SSRI use in children and adolescents is associated with a higher risk of delayed puberty. A large cohort study found that kids with depression or anxiety on SSRI had about a 44% higher odds of delayed puberty diagnosis compared to similar kids not on SSRI. The absolute numbers were small, but the signal was real, and the authors hypothesized that HPA access could be affected. Smaller studies and clinical reports indicated SSRI induced sexual dysfunction in teens. One chart review found around 23% of adolescents on SSRI had sexual side effects, which is probably underreported. In other words, we're modulating serotonin and possibly prolactin in a developing brain-testy communication, and we're seeing hints that it slows or alters normal puberty in some kids. On the steroid side, long-term daily systemic corticosteroids in children clearly suppresses the brain-testy communication and can impair growth. Classic pediatric work shows kids on daily divided dose steroids failing to grow, while alternate day regimens had far less impact on growth and HPA function. More recent work on in utero and early life glucocorticoid exposure suggests timing of puberty can be shifted through brain-testy interactions. So here's my stance. SSRIs and systemic steroids have a place in severe, carefully selected cases with clear indications and risk-benefit reasoning. But they should not be the default first line for every anxious teenager or every mild inflammatory condition, especially when we haven't exhausted lifestyle, therapy, and non-endocrine disruptive options. Because once you start modulating the HPG axis in kids with SSRIs, chronic steroids, you're playing with the systems that govern growth, puberty, and lifelong reproductive health. Now back to our guy. Instead of just putting him on TRT and calling it a day, we addressed sleep and possible apnea, overhauled his nutrition and visceral fat, built a resistant training program focused on muscle and strength. Simplified and tapered medications were appropriate, including working with his prescribing provider to reevaluate long-term SSRI use. Cleaned up his environmental exposures like plastic, personal care products, canned foods. We also had an honest conversation about TRT, what it can do, what it can't do, and what we'd be committing to if we started. For him, we did eventually use TRT, but at the lowest effective dose and in the context of a full risk reduction plan: labs, hematocrit, blood pressure, lipids, and lifestyle changes. The key is TRT became one tool in part of a broader plan, not the entire plan. That case changed how I treat men because it forced me to see each low T lab as a tip of the iceberg. environmental endocrine disruptors, childhood and adolescent medication exposures, lifestyle and metabolic damage, traumatic brain injuries, which is a whole video in itself, and yes, sometimes genetics and bad luck. If we don't at least look under the surface, we're just handing out band-aids, and that's not how I practice. So what do I want you to take away from this? Low testosterone is almost never just bad luck. It's many factors: environmental chemicals, poor metabolic health, chronic stress, chronic sleep deprivation, bad diet, and in some cases, medications. Doctors like Dr. Thomas O'Connor have shown us what happens when we ignore that and treat androgens casually. Men end up sick, hypogonadal, and scared because of the lack of providers in this space to help guide them. We can do better by combining his harm reduction mindset with naturopathic root cause thinking. My philosophy is this: build your health foundation first. Use the lowest effective dose of any hormone or peptide. Change one major variable at a time. And never forget that your environment and your past meds are part of your whole hormone story. If you want a follow-up video where I walk you through exactly how I work up a new low T patient, labs, history, environmental review, before we ever talk about dosing, let me know in the comments and I'll build that next. And if you're a man who suspects low T and you've already been offered a one-size-fits-all TRT script without this kind of deeper workup, check the link in the description and schedule. That's where I'll walk you through what it looks like to work together. As always, subscribe for more evidence-based videos on testosterone, peptides, and men's health. See you on the next one.